Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. Thank you for the nice introductions, and thank you for the scientific committee for inviting me to talk about one of the critical topic in IBD, caring for the hospitalized UC patients. So here is my disclosures and the objectives for the talk. Initially, we're going to start with the definition of the acute severe ulcerative colitis and the quick review of the diagnostic practices, then address the management of the complications such as the infections and the steroid failure, and finally, we will discuss the risk stratification and the treatment option therapy. So we know that acute severe ulcerative colitis, it is a serious condition. And the definition is the presence of the 6 or more bowel movement accompanied by at least one of systemic sign of the toxicity, tachycardia, fever, anemia, or elevated inflammatory markers, either the ESR or C-reactive protein. So the acute severe ulcerative colitis is not a rare disease. It can affect 25% of the UC patient develop the acute severe ulcerative colitis. 30 to 40% of them, they will fail the steroid therapy, and 18% of the patient, they will acquire colectomy. So this is the ACG, proposed ulcerative colitis activity index, and they classify it to the 4 categories: the remission, mild, moderate, severe, and the fulminant, and they including the several markers here. And this is recently they add the urgency and the fecal calprotectin, and I think also the fecal calprotectin to be included here can help us in the our clinical practice. So the first day of the admission by the patients with the first day of admission of patients with acute severe ulcerative colitis, we will perform the blood test, CBC, electrolyte, CRP, ESR, and lipid profile. Then obtain the abdominal X-ray and consider the CT scan if it is indicated. Check the stool and rule out the infection, and the most important is the C. diff. And also do the flex sigmoidoscopy the second day unprepared to rule out CMV colitis, and test for tuberculosis and hepatitis B to prepare for any rescue therapy, and investigate for the deep vein thrombosis and start prophylaxis, and consult the surgery early. Please keep the surgery on board from the first day. So one of the most important factor for the disease assessment and the disease course is the ulcer. So deep ulcer mean the patient is coarse and the high risk patients. So there are 3 main objectives from doing the flex sigmoidoscopy. The second day is the assess the inflammation severity, to confirm the IBD diagnosis if it is uncertain, and to rule out the CMV colitis. So the C. diff infection is really, it is something significant and serious consideration. So as the IBD patients increase the risk of 4.8 times to have C. diff infection comparing to the non-IBD patient. And also, those patients with the positive C. diff, they have increased risk of the colectomy almost 3 times to those patients without infection. There are some risk factors that increase the risk of the infection: more extensive disease, severe disease, and immunosuppression therapy. So the testing for C. diff is a little bit complicated with the multi-step testing algorithm, including the both high sensitive and specific test, and should be used for the diagnosis. However, the treatment should not be withheld when there is high clinical suspicion, even if it is the test is negative. So regarding the treatment, the vancomycin is the first line therapy treatment in the C. diff in IBD patients, and metronidazole should not be used even if it is the first episode. And one important point here that you will treat both UC and C. diff at the same time. Also, regarding the antibiotic course, we give little bit longer than around more than 3 weeks, because this will decrease the risk of the recurrence. Regarding the CMV colitis, also this is another important infection that should be addressed during the acute severe ulcerative colitis. We know that active UC will increase the risk of the CMV colitis, and the CMV colitis will worsen the activity of the UC. So the questions here is the treat active UC first, or you will treat the CMV colitis, or you will treat both at the same time. CMV also is not a rare disease. The prevalence reach up to the 38% over all the prevalence, and reach up to the 34% in severe ulcerative colitis, and more common in steroid refractory colitis. There are some risk factors for the CMV colitis: female gender, pancolitis, age more than 30 years, disease duration less than 5 years, exposure to the immunosuppression therapy, and high dose of steroid. So regarding the CMV infection, there are 3 clinical spectrum of the CMV. CMV infection, that means the presence of the CMV antigen or antibody in the blood. CMV colitis, that means the presence of the virus in the colon inside of the inflamed tissue without damage the tissue, and this is what we call the innocent bystander. And the last one is the CMV disease, the symptomatic end organ detection, clinical symptoms, and tissue damage. So regarding the treatment plan of the CMV infection, it's really depend on the clinical spectrum. So if we go from the latent to the disseminated or the CMV disease, usually the patient will get a benefit from starting the antiviral therapy, while those patients with the latent and CMV colitis will get a benefit from treating the disease activity. So here is the summary for the treatment of the CMV colitis. When you suspect about the diagnosis, if you have acute severe ulcerative colitis, patient with steroid and thiopurine refractory disease, and deep ulceration in the endoscopy. So you will send for or to confirm a diagnosis by the histology or by immunohistochemistry or the tissue PCR in the colon. So the treatments, actually, it's depend on the immunohistochemistry inclusion bodies. So those with the more than 5 inclusion bodies, they consider as high-grade disease. So we consider the CMV treatment and start the antiviral therapy, taper the steroid, and consider stopping the thiopurine, but the anti-TNF is safe. Those patients with the low-grade infection, that means you will treat the disease activity other than the virus. It's really another important point here that those patients that admitted with acute severe ulcerative colitis, the DVT prophylaxis. So this is a retrospective study including more than 300 UC patients admitted between 2007 to 2011, and the overall, the DVT prophylaxis is 67%, while the prophylaxis in the medical patients is around 57%, while in the surgical patients is 93%. So the surgery, they are doing better than us. In the missed dose in the medical patient is a 34%, and the missed dose in the surgical patient is 17%. So this is highlight the importance of the giving the DVT prophylaxis, as we know that those patients that admitted with the acute severe ulcerative colitis, they have a higher risk than those patients in non-active disease. So since 1955, still the cortisone is the primary treatment for the severe UC. And this is a small study that compared the hydrocortisone 100 versus the placebo. That time showed the clinical remission is a 41% comparing to the 16% in placebo group, and the mortality is less in steroid group, 7% comparing to the 24%. So around 67% of the patients receiving steroid treatment show positive clinical response. So the ACG guideline recommend a total of 60 milligram methylbrite or hydrocortisone 100 milligram to induce remission. So from the second and the third day, we need to evaluate the daily symptoms, monitor the inflammatory marker, especially the CRP, do the abdominal X-ray if it is indicated, assess for the response to the IV steroid using the predictive markers, and for those patients that respond to the steroid may continue IV steroid for 3 to 5 days, then consider the switch to the oral prednisolone. For those patients that not responding to the steroid by day 2 to 3, you should consider the rescue therapy. So here is some markers that can help us and predict the steroid failure and the need for the rescue therapy. One of them, the Oxford criteria, that the stool frequency more than 8 times or stool frequency more than 3 with the CRP more than 5. This can tell us that around 85% of the patient, they will have colectomy. So there are two main important medication for the rescue therapy, the infliximab and the cyclosporin. And we know that infliximab and cyclosporin, both they are effective in the treatment of the steroid refractory acute severe UC. And this study showed that around 115 patients, they comparing the infliximab versus the cyclosporin, and in the term of the treatment failure, colectomy rate, severe adverse event, steroid-free remissions, and clinical response, there were no difference between the two medications. So those two medications is effective treatment for the rescue therapy with the same efficacy. As we know that to choose between these two medications, there is a potential contraindication for each one. Infliximab, the untreated latent TB, congestive heart failure, demyelinating disease, and active infection, except the C. diff. In cyclosporin, will decrease the threshold for the seizure, renal insufficiency, low cholesterol level, active infection, and lack of the local expertise in the administrations and monitoring of the cyclosporin. So it's very important to know that the low albumin and the elevated CRP level will impact on the infliximab exposures. So as we can see here that those patients with the high CRP, the concentration of the infliximab is around 500, while those patients with less CRP or less than 50, it's increased more than doubling, more than 1,000. So there is increase of the infliximab clearance with the high CRP, and in albumin also we see the same one with the low albumin. There is decrease of the infliximab exposure, but it is less significant than CRP. So what about giving IV albumin with the infliximab, if this will help the infliximab exposures treatment outcome? So this is a study done a single center randomized control trial of the 61 patients, and the two groups, one of the albumin arm and the standard arm, and they found there is no difference between the two groups in the term of steroid failure rate and also in colectomy rate. So the evidence showed there is no benefit from giving IV albumin to those patients with the acute severe ulcerative colitis. So as we know that there is clearance, there is leakage of the drug. So what about increasing the dose? So if there is leakage of drug, so does more mean better? This is a recent published study called Predict UC. It is an open-label, multi-center randomized control trial. They include around 138 patients with the steroid refractory acute severe UC. As you can see here from the study design, this is one of the most complex study design. So they start with the first randomization of the patients. They divide it to two groups, the standard dose and the intensified dose. In the standard dose, they give 5 milligram per kg, while the intensified, they give 10 milligram. Then for the standardized group, they do another randomization to standardized induction and accelerated induction. In the standardized induction, they give 5 milligram at week 0 to 6, and if there is no response, they will give another 5 between day 3 to 7. In accelerated induction dose, they give 5 milligram 013. If there is no response, they will give 10. So what about the outcome? The outcome between the standardized and intensified and the accelerated, as you can see, there was no difference in the clinical response by day 7 and day 14. There is no difference in the clinical remission, endoscopic remissions, and also in steroid-free remission, and in the colectomy rate. So there showing there is no added benefit from the intensified or the accelerated dose, and as we can see here also the p-value is non-significant. So what about the subgroup of the patient that they have high CRP and low albumin? This is the post hoc analysis from the PREDICT UC, and showed also there is no benefit from adding the intensified dose 10 milligram in those patients with low albumin and high CRP. Numerically is better, but statistically non-significant. So now we're going to move to the another modalities of the treatments, another mechanism, the JAK. So this is a tofacitinib in the acute severe ulcerative colitis, as we can see here in the single center study, around 100 patients. They divided in two groups, tofacitinib 10 milligram 3 times a day versus the placebo for the 7 days. As we can see here, there is a signal of the benefit from the tofacitinib in patients with acute severe ulcerative colitis, as we can see here, and also in the need for the rescue therapy. And regarding the colectomy rate, it is less in the tofacitinib group comparing to the placebo group, and also this is statistically significant. The upadacitinib, also there is a promise that may get a benefit from the treat the patients with upadacitinib. In this study, the 100 of the patients, they already infliximab exposed. As we can see here, that the 90 days colectomy rate is 24%, steroid-free remission is 83%, venous thromboembolism event is 4%. So there is a signal that upadacitinib is a promise and working for the acute severe ulcerative colitis. So what about the third line? If we failed the first line steroid and the second line of the infliximab or cyclosporine, is there any role for the third line? This is assessed in this multi-center retrospective cohort study. As we can see, it is around 78 patients, 32 infliximab and 46 cyclosporine. And those group in the infliximab, 17 of them, they received cyclosporine, 13 tofacitinib, and 2 ustekinumab. And in the cyclosporine group, 45 infliximab and 1 ustekinumab. So as we can see here, that around 50% of the patient, they response, clinically response, and also the colectomy-free survival is around 50%. So this is the network meta-analysis. As you know, the network meta-analysis, it is the indirect comparison between the medications. As we can see here that tofacitinib, accelerated infliximab, standardized infliximab dose, and tacrolimus, they significantly reduce the rate of the colectomy in patients with steroid refractory acute severe UC compared to the placebo. So between the day 7, between the day 4 and 7, we need again to decide whether to continue the medical therapy or consider surgery, reassess the patient condition. For those on rescue therapy, evaluate the response and consider next. And next step, either to continue the treatment, switch another therapy, or proceed to surgery. So this is an important post-hoc analysis from the TRIUMPH study that there is a predictor at the day 7. And they found that if the rectal bleeding subscore is 0 by the day 7, the clinical remission is reached up to the 75%, and the endoscopic improvement is 62%. So the rectal bleeding subscore by day 7 was significantly associated with week 26 steroid remission and endoscopic improvement. So what about the follow-up? This is interesting study that the impact of the timing of gastroenterology follow-up on the readmission rate after the admission of the severe UC. And they found those patients that seen after 1 week from the discharge to be without readmission is reached up to the 76% comparing to the other group that saw the patient after 2 weeks or more than this. So this is an emergent therapy in the treatment of the acute severe UC, the hyperbaric oxygen therapy. And as we can see here is the phase 2A randomized double-blind study. They include around 18 patients with the two group, the hyperbaric oxygen versus the placebo, and it was better in the clinical remission at day 5 and clinical response at day 10. But there was no difference in the colectomy. So this study is still going on, and also there is a signal that maybe this is we will have some modalities of the treatment in the future. So the conclusion, the acute severe UC is a serious condition affecting about 25% of the patients, and 40% of them, they were not responding to the therapy, and 18 requiring the colectomy. Early diagnosis, risk stratification, and multidisciplinary management are crucial for the optimum outcome. Steroid remain the first line therapy. The infliximab and cyclosporine both are equally and effective as a rescue therapy. Emerging therapy, the JAK inhibitors like the tofacitinib and upadacitinib may consider in the treatment. And also the novel approach like the hyperbaric oxygen therapy may offer additional benefit in the managing of the severe UC. Also, the follow-up after the discharge is significantly reduced the admission rate for the UC patients. Thank you.